Guys, welcome back. I shall now be explaining to you regarding inflammatory bowel disease, namely ulcerative colitis and Crohn's. The first and the foremost concept that I want you to understand is that this is not an autoimmune disorder. Well, surprising, because when you read regarding diseases like SLE, rheumatoid arthritis, Hashimoto's thyroiditis, and inflammatory bowel disease given in a question, the impression is that all of these are autoimmune, but I'm telling you that inflammatory bowel disease is purely inflammation, but not an autoimmune disorder. I know I'm gonna get a lot of queries on this because later on when I'm gonna talk about antibodies which are gonna be associated with this disorder, the usual query is that, sir, you talked about some antibodies, so why is it not autoimmune? Well, first of all, I wanna tell you that this particular disease, why does it develop? The reason why it develops, the concept behind that is technically called as hygiene hypothesis. Let us try to understand what it actually means. You see, in developing countries like India, where hygiene is not gonna be so good, we Indians are exposed to a lot of infections in our GI tract right from our childhood. So our immune system is trained, mark my words there, our immune system is trained to differentiate between the good bacteria and the bad bacteria. Obviously, the good bacteria are gonna remain and the bad bacteria are the ones which are gonna be destroyed. But in Western population where the incidence of infection is lesser, the immune system is not trained properly. Because it is not trained properly, it might actually produce some cytokines that might cause gut inflammation. One of the cytokines which is involved in pathogenesis of both Crohn's and ulcerative colitis is TNF alpha, that is tumor necrosis factor alpha, and this is because the immune system is not trained properly. So the basic concept behind hygiene hypothesis is, and I would call that a blessing in disguise for Indian population. I mean, you guys would have seen that IBD per se, the incidence is lesser in Indian population as compared to your patients who are coming for medical tourism. And medical tourism is booming in India because the medical care costs are relatively lesser. I would also like to reiterate my statement. The questions that was asked in the AIMS exam had 4 options: SLE, inflammatory bowel disease, Hashimoto's, rheumatoid arthritis, Graves, and well, the question said, which of the following is not an autoimmune? I've just told you the answer, and this is to be remembered as an inflammatory disorder due to misfiring of the immune system that causes gut inflammation. Now, since you would have studied this in pathology also, so I think this was like hitting the nail on the head from the pathogenesis domain. Let's now understand some very basic facts about this condition. This condition, Crohn's per se, can affect whole of the gut. But if he specifies that it is the leading side that is afflicted, then your answer would be given as ileum. On the contrary, he might even ask you opposite of this, that which part of the GI tract can be spared in a patient of Crohn's disease, then the answer would be given as rectum. Do remember the fact that though the entire gut can be involved, but these predilections are definitely to be remembered. If he says what is the earliest presentation of this disease versus earliest histopathological presentation, then I want you to remember that when it comes to this particular disorder, there's gonna be ulcers in the gut which are gonna be called as serpiginous ulcers. Let me just write down the name here, serpiginous ulcers, and I'll put up a question before you while I write down more information. Can you tell me a condition where you read about serpiginous ulcers in the esophagus? Remember, it's a virus, the virus that causes serpiginous ulcers in the esophagus. In Crohn's disease, the serpiginous ulcers could be present along the entire length and breadth of the GI tract. This is gonna be a full thickness involvement right from the starting to the end. The whole of the gut, the small and the large gut is involved. But the question is serpiginous ulcers in the esophagus is a feature of. That's the question to you guys. Yes, guys, can you tell me from pathology, where have you read about this? in entire medicine domain, you're gonna read about serpiginous ulcers in the intestine 2 times. One is the topic that I'm gonna teach you, Crohn's. Second, additional detail that I want you to remember is if he specifies the word serpiginous ulcers in the esophagus is encountered in, then your answer would be given as CMV, cytomegalovirus. Now, my query is, what is the earliest histopathological finding in this patient? Well, there is ulcer formation, but lots of time in multiple choice question, instead of writing the word serpiginous, he might just write the word standard aphthous ulceration. You see, aphthous ulcer can happen in any one of us, maybe due to stress, due to constipation, maybe once in 5 years, and maybe eating spicy food will be a little bit of trouble for few days. So most of us don't do anything about it. Most of us avoid taking spicy food for a couple of days, and the aphthous ulcers will tend to heal by themselves. But when it talks about Crohn's disease, the aphthous ulceration is not going to be once. It's going to be recurrent affair. It's going to occur all around the year. It's going to be recurrent aphthous ulcers. One is going to heal and two or more are going to develop at the same site or at a different site. You see, for aphthous ulcers in a normal individual, which can occur because of stress, because of constipation, you don't need to note this down. Lots of time you might have used jellies like Zyte lotion, etc. that are containing topical benzocaine. So most of the time, the aphthous ulceration that occurs in a normal person, I repeat once, why can it occur? It can occur idiopathically. It could be due to excessive stress. It could be constipation. They tend to self-heal by themselves. But imagine a gut full of aphthous ulcers everywhere. Some areas are normal, some areas are definitely involved, and these aphthous ulcers could be having even a full thickness involvement. The highlight from exam perspective, if he says what is the earliest histopathological examination finding of these patients, your answer is going to be aphthous ulceration. These ulcers can go much more deeper. The ulcers can develop, let me say, I can represent this in one of the diagram. You see the ulcer will go deeper. It will go from mucosa, submucosa, then will cut through the muscularis mucosa, even go and damage the serosa. So it's going to be not one. It could be like multiple such ulcers going through and through the entire thickness of the guts. That is why we call it a transmural involvement. But because these ulcers are gonna be very deep and are gonna look like a snake, that is why the word is serpiginous ulcers. Whenever these ulcers will develop, there will also be a associated submucosal fibrosis below the ulcer, because the body will try to limit the progression of this ulcer. Because of this submucosal fibrosis, another thing will creep up, which is gonna be that the mucosa of this person will be having an irregular appearance. Yes, you all know this from pathology domain. The irregular appearance of the mucosa of the entire gut in this particular patient is called as cobblestone mucosa. There is also possibility that the ulcers may not be occurring in a contiguous fashion. It might be like one area of the gut involved, then for another, let me say 10 centimeter, the whole of the gut is normal, then again some part is involved. So you are anyway familiar with the word skip lesions. Well, I spoke about these terminologies just to get the familiarity back in this topic. And what is the importance of studying this? I mean, the importance of studying all this is that wherever there's going to be ulcer or ulcers, there's going to be a submucosal fibrosis which will cause stricture formation in the intestine. Because of the stricture formation in the intestine, which is visible on the colonoscopy, capsule endoscopy, or even a barium meal follow through, because there's a stricture, the problem is that food is not going to be able to navigate through it. So the intestine will contract with more force to overcome this physical obstruction. What I've shown in this diagram is not one, but multiple strictures all through the gut. And because of these structures, because the intestine will contract with more force to overcome the obstruction, therefore there's going to be round the clock colicky pain developing in this person. A lot of patients of Crohn's disease, when they initially come to you, will mostly not be Indian patients. They're gonna be like because of medical tourism, they are gonna be coming from abroad, though can be an Indian patient as well. And then there's gonna be standard presentation of colicky pain for which he's using tablets like Meftal Spas. You're all aware of this common brand, if a person, like in India, people tend to go to a chemist and say that I'm having tummy pain, can you give me a tablet? And the chemist will cut 2 tablets and give it to the patient. That is going to be Meftal Spas, mefenamic acid and dicyclomine. That's an antispasmodic agent and the patient is going to feel fine. But in this case, he's saying that I've been taking it for 2 months, 3 months, daily 2 tablets of Meftal Spas, 3 tablets, and still the pain is persisting. Well, let me just explain to you what I meant by serpiginous ulcers in this case, so I can just use this opportunity to mention regarding the mucosa and the submucosa. Then we definitely have muscles present. You see the muscularis externa, muscularis mucosa present in the gut. And why am I drawing that is to explain to you that if these muscles are damaged, then the motility of the gut is also hampered, and because the motility is hampered, the gut will dilate. That is why lots of time you read the word toxic megacolon. The toxic word is mainly to highlight regarding the toxins which are being produced by the bacteria in these serpiginous ulcers, and at the same time the gut is dilated, the motility part is hampered. We'll also study the definition of the word toxic megacolon, but at the moment I just want you to understand that the motility of the gut can be severely hampered in these patients. There could definitely be a possibility of damage to blood vessels. You see, if you are having, let me say hypothetically, if I just show blood vessels, then the ulcer will go deeper, it will damage the blood vessels. It can damage the mesenteric plexus. In fact, in this disease, the ulcer can reach as far as up to the serosa. And the ulcer goes so deep that it damages the serosa, then there's gonna be pus appearing on this particular side. Let me just hypothetically show you a couple of ulcers so that this becomes better appreciation for you guys. I am here sketching an ulcer going deeper, damaging blood vessels, damaging even the muscles, and then ending up with a possibly damage to the serosa. It's not gonna be one, it's gonna be like multiple. It's gonna be multiple such ulcers present here, looking like deep, having a snake kind of an appearance. That is why the technical term is serpiginous. Why am I drawing this is to highlight to you that now you see on this side are the bacteria in the lumen of the gut, and they'll get access directly into this ulcer. So on the contralateral side, there is appearance of pus. And once the pus will appear, then the policeman of the GI tract, the omentum will try to wall it off. This explains the fact that why do you read about fever that is usually spiking fever with chills and rigors that can be seen in patients of Crohn's, because you are literally having a formation of intra-abdominal abscess. And even if you give antibiotics and cause resolution of this abscess, there could still be development of adhesions between the two parts of the gut, and in fact there could be even a fistula formation in these patients. You see, the earliest presentation from clinical domain of these patients would be a round-the-clock colicky pain that will even interfere with this person sleeping, because the ileum of this person is damaged. And ileum is the site where there's gonna be bile acid plays an important role in bile acid metabolism. The bile acid metabolism is distorted. As an end result, there would be bile acid diarrhea also occurring in these patients. The reason why you read bile acid diarrhea being written in these patients is because if you read regarding the metabolism related to bile acids, then the small gut and the ileum plays an important role. In this case, that is distorted, structurally damaged. It's a mucosal disease. The third thing that will come up in this person would be damage to blood vessels that can contribute to hematochezia. When I've talked about the topic of bleeding from the gut, even there I've elaborated regarding that hematochezia can be a presentation of Crohn's, though is more pronounced in ulcerative colitis. Since the motility part can be hampered due to damage to the muscles, the muscularis externa, the muscularis mucosa, which is highlighted here, then toxic megacolon can develop. Well, once toxic megacolon will develop, it's definitely a bad prognosis and might even necessitate a surgical intervention. You have to remember that if the bowel loop is grossly dilated, let me say if a person is having toxic megacolon, where the word is colon, so we're talking about large bowel here. So the bowel loop should be on an X-ray more than 6 centimeter size to say that it is megacolon. Most of the time, the toxic megacolon can involve the transverse colon. So remember T for toxic and T for transverse colon involvement in these patients. The bad news is that there could be a development of intra-abdominal abscess in these patients. You can see the pus appearing on the side of the serosa, and even if you give the antibiotics, the pus will be reabsorbed, but adhesions can develop. Now, once these adhesions will develop, that is where the real problems can come out. Like no surgeon loves to or likes to operate on a person of Crohn's because there is adhesions between the gut. So there's a possibility that when you're operating on this guy, the adhesions might contribute to more trauma. It might even cause a fistula formation. In fact, you see, even if, you are trying to do an end-to-end anastomosis of the bowel, like you are resecting the defective part, putting up a end-to-end anastomosis, the bowel wall in some cases can be so friable that when the surgeon will put sutures in the gut wall and then once he will put the knot might actually cut through the tissues of the gut. The friability of the gut wall is dramatically increased in these patients. Apart from these adhesions can occur between the bowel and the fallopian tube. Let me say it's a female patient of Crohn's, and she's having these adhesions developing between the bowel wall and the fallopian tube. Now the bad news is that the course of the fallopian tube will be kinked, and that can explain why infertility is written in patients of Crohn's but is not seen in ulcerative colitis, because in ulcerative colitis you don't have this presentation of intra-abdominal abscess formation, so there are no adhesions that are developing and therefore there is no infertility also. Do you remember this statement, though it's a very minor one? Infertility is a feature that you read in Crohn's but not in patients of ulcerative colitis. Now, the seventh manifestation of these patients is the main reason why you need to understand this topic from the clinical domain, because this is a hallmark feature of Crohn's. I mean, if the question highlights the statement, which of the following is the most characteristic manifestation or a hallmark feature of Crohn's disease, your answer is going to be fistula formation. These fistulas are going to be nasty because the quality of life of this person will now be hampered big time. To explain this fistula formation, I can just draw this crude diagram here. Let us assume that I've shown the representation of the anal opening. That's the anal canal. The length of the anal canal, you're aware from anatomy, is 4 centimeter. And then is going to be the rectal ampulla. This is the rectum where the feces are stored. I have here symbolically shown one of the muscles related to the levator ani, that is the pelvic diaphragm, and this is the puborectalis muscle. In fact, just to make it more anatomy oriented, I think all of you are familiar with what we call as the anorectal angle. You can see the anal canal, you can see the rectum. The normal anorectal angle is 120 degrees. When a person will defecate, the alignment changes and the feces are able to come from the rectum into the anal canal. Now, the bad news in this chap is that there could be an ulcer formation. Please give me undivided attention on the slide for next 10 seconds. There's a distinct possibility that there might be ulcer that might develop in the anal canal of this person, it will have this snaking course. It's running through the istiorectal fossa, and then it might create a small opening anterior posterior to the anus, from where there will continuously be a foul-smelling discharge. In this particular diagram, what I've tried to do is, I've tried to show here is a fistula or a fistulous tract. This is a small opening, let me say posterior to the anus of the person, from where bad smelling secretions would be present. Well, if you study the anatomical component, you read about the anal canal, you read about dentates line, etc. In the upper part of the anal canal, we have some glands which are called as glands of Ball. They are the ones which produce malodorous secretions. They are the ones that produce foul-smelling secretions. So all these foul-smelling secretions would be coming out from the fistulous opening and would be staining the undergarments of this person. Because this is gonna smell bad, so the person himself, he might, if a person is having this discharge, he might get used to the bad smell, but his friends or his relatives will definitely find this guy smelly, so they might make fun of him. So you will notice that a lot of these patients of Crohn's might be having low self-esteem and less self-confidence because they smell bad. You see, they would be staining on the undergarments of the patient. That's itself, something that's gonna make the person feel unclean and dirty. And at the same point of time, if the family members are ridiculing this person, then I can reiterate the fact that, the self-confidence of the person will definitely take a hit. Fistula formation is a hallmark feature of Crohn's and is not seen in persons of ulcerative colitis. In multiple choice question, because he knows that you will be able to answer it right away, so he might use alternative terminologies, like you would have always read about perianal sepsis or poor personal hygiene written in these patients. There is always a malodorous discharge that will stain the undergarments of this person, so he is always gonna feel dirty. The worst scenario is that imagine there is a fistula formation created between a fistular communication between the bladder and the colon. Now imagine if the colon is hooked onto the bladder, then the fecal matter is gonna be transported to the bladder, and that's gonna cause extreme amount of cystitis and then subsequently a severe amount of UTI. So there can even be a vesicocolic fistula in these patients. Most of the time, there might even be a fistula that might be opening in the anterior abdominal wall. Looks very surprising. A fistula opening into the anterior abdominal wall communicating with the gut is called as anterocutaneous fistula. So there can be 3 of them that could be occurring simultaneously in a patient, and well, it will be difficult to manage. I'll talk about drugs from pharmacological domain that is going to help these patients and help these patients get their lives back on track, help these patients feel more confident about themselves, because lots of time when you send these patients over to the surgeon for surgery, the surgeon will refuse. You see, the surgeon will refuse to operate on these guys because they have a friable gut wall, and even if you operate, there's a possibility that a new fistula will develop at the same site or at a different site. So the relatives of the patient might fight with the doctor that you did not operate properly, as happens in our country. So lots of time you will find surgeons very, very reluctant to handle these patients. Mostly it's the medicine department that would be handling. Obviously, if it's a surgical emergency, things are different, but otherwise, mostly surgeons try to avoid these patients for even fistulectomy because there's a tendency for this to develop once again. I shall now be explaining to you regarding the workup of these patients of Crohn's disease, and the first test that I'm gonna run is called as ASCA antibody. Well, the name is anti-Saccharomyces cerevisiae antibody. That's what examiners love to always hear and ask you in the exam. In contrast, I am very sure from your pathology classes you are familiar that P. ANCA is related to ulcerative colitis. Once you get the antibody right, then he's gonna ask you what is the imaging modalities available for this condition. So let's prefer the one that is most suitable. The most suitable one would be that send in a camera in the gut and see the cobblestone mucosa, evaluate the strictures and see multiple aphthous ulcers. So one of the ways to scan this person's gut would be to preferably do a capsule endoscopy. Now, practically speaking, in India, capsule endoscopy may not be feasible. So you definitely will be having access to the standard colonoscopy as well as upper GI endoscopy. And I've written both in this case because this condition has a predilection to involve both the small bowel as well as the large bowel. It can also be advantageous to do a biopsy because here you can go on for a directed biopsy. What I imply by directed is you seeing a lesion, so you can do a biopsy. And the finding that they would love to ask you from pathological domain here will be that they would be granulomas present. Obviously, they would be non-caseating because you're aware caseating is found in tuberculosis, histoplasmosis, cryptococcosis, but here it would be non-caseating granulomas. We do not get granulomas in ulcerative colitis. Why this is important is because lots of time in pathology domain, they might use the term granulomatous colitis, that is Crohn's. If they use the word non-granulomatous colitis, it is ulcerative colitis. But yes, sending in a camera, seeing the lesions, taking a biopsy from the lesions is the best way to identify this. Now, if a person is not willing for this kind of imaging, then I again have a backup available, which is I can make the person drink contrast and I can go in for CT enterography. So, in the exam, capsule endoscopy is the first priority. I mean, if you can see something with a camera, what better evidence? But because that's going to be relatively an invasive procedure, a person may not be willing for it, or it might be even costly. So we can try a CT enterography. In contrast, lots of times surgeons would love to talk about barium meal follow through because surgery books are full of images, the older ones that were used for this particular condition, where we are able to see multiple strictures in the gut. You see, barium meal follow through or small bowel studies. You see, the small bowel study per se is itself an MCQ. No, I'm very sure from your surgery classes you are familiar that the small bowel evaluation is the one that we called as enteroclysis. So I agree to the fact that the surgeon will mainly speak about point number 4, but I want to tell you the fact that these are relatively the older investigations available for this condition. As of today, the best way is go inside the bowel and see what the disease process is and how it is progressing. Barium meal follow-through will be able to demonstrate multiple strictures, and one of the reasons why they speak about it is because they want to talk about this classical finding. Now, I hope you would agree that in early presentation of the disease, this classical stricture, this classical strings and cantor may not be present. So, I'm not discrediting point number 4. Yes, it is done, but the findings will occur very, very late. Whereas you can pick up the aphthous ulceration, then the formation of cobblestone mucosa relatively early in these patients by sending in a scope inside with a camera, and you have a direct evidence of the fact that there is something wrong in this person. Coming to the treatment of patients of Crohn's disease, if the MCQ says what is the drug of choice for this condition, do not answer sulfasalazine. I've seen a lot of doctors casually mentioning sulfasalazine. I'll tell you the reason why in few seconds from now, but I just want you to remember at the moment the answer would be given as steroids. Along with this, because most patients would be having bile acid diarrhea, so we need to handle that. Reason I told you, reason for bile acid diarrhea in Crohn's is because of the primary damage to the ileum of the person. The agents which are available here are in the form of cholestyramine. Second is the bile acid sequestrant that you are available or aware by the name of cholestyramine. Do remember the fact that when it comes to sulfasalazine, this is actually a prodrug. When I say a prodrug, this is acted upon by the bacteria in the large bowel and then is converted into the active metabolite that is called as 5-ASA. ASA would stand for amino salicylic acid. It's not acetyl salicylic acid, it is amino salicylic acid. This is the one that exhibits local anti-inflammatory action. This is the one that exhibits an anti-local inflammatory action, which is responsible for healing of the ulcers. But the issue is that you need bacteria for this active metabolite to be produced. And the bacteria are present only in the large intestine. No, bacteria are not present in the small intestine. So if you are gonna give sulfasalazine to this person, the bad news is that the small bowel disease will not be corrected. The large bowel disease will obviously be corrected, but the small bowel disease would remain just like that. So instead of using sulfasalazine, we might be using mesalamine for these patients. So therefore, in the exam, you will read about steroids, you will read about controlled release preparation of mesalamine. But at the same time, I want you to remember the fact that if they ask you to give single best answer, your answer would be given as steroids. Other immunomodulatory agents can also be used in a step-up therapy where we can use azathioprine, or we can be using additional molecules like which will obviously have side effects. I mean, the side effect profile will keep on increasing, but at the same time, you see, you need to balance it out. Now, one of the big problems of these patients is fistula formation. So I sent this person over to the surgeon for a fistulectomy. I wrote a note that this person was having a perianal fistula, and I got a fistulogram done and then have referred this person to surgeon for this procedure, but the surgeon refused. You see, surgeons obviously operate by rules and ethics and indications, but lots of time nowadays, even reputation plays a role where people are going to be rating you on all these various apps available, and at a slightless provocation, they might just downgrade their rating, and a surgeon is definitely not going to like it. So, the surgeon has refused to operate on this case in spite of my recommendation, and I gave a personal call to him. I said, "Sir, I sent a case to you. You refused." He said, "Yes, boss, I have refused to operate on this chap because there is a perianal fistula, but there's a tendency for this disease to reoccur. So even if I operate on this guy, tomorrow a new ulcer will develop at the same site or a distal site, a proximal one. The patient will blame me." So this person has come back to me and he says, "Sir, don't you have anything available?" Because the surgeon is not willing to operate. In those circumstances, we can definitely be using infliximab for these patients. Infliximab, as you are aware from pharmacology, is a tumor necrosis factor alpha antagonist. And the movement assay antagonist, you will realize the fact that when I started this discussion, I was blaming TNF alpha for the inflammation in the gut and the formation of ulcers. If you neutralize it, you're bang on target on treating this disease. The textbook categorically mentions that infliximab has been documented to cause healing of enterocutaneous fistulas also. You see, when it's a perianal fistula, there are multiple problems, even in the form of infection, no? So, in a perianal fistula, the first thing that you need to do for healing is not infliximab. First and the foremost is maintain the hygiene component, give an antibiotic course, because infection itself will prevent the healing of the fistula. So in a perianal fistula, obviously things are little more complicated than an enterocutaneous one. So I've written enterocutaneous there primarily because here only one factor is operating. TNF alpha, I can neutralize it. But in perianal one, it's multiple factors that are operating for this person. I shall now be comparing features of Crohn's disease with that of PMC, that is pseudomembranous colitis. We first need to practice why would you be having PMC. Well, it is always suspected when a person has taken a course of antibiotics. There's a balance between the good bacteria and the bad bacteria in the gut, and when you give antibiotics, this balance is distorted. So the nasty fellow that will overgrow and will contribute to toxin-induced damage is Clostridium difficile. From the exam perspective, we need to remember this disease is to be suspected when the patient has taken antibiotics in the previous, and the cutoff is again important, because if somebody has taken an antibiotic course 1 year back or 2 years back, we're not going to say that the diarrhea episode now is going to be due to pseudomembranous colitis. So remember, MCQ wise, person has taken antibiotics in the previous 3-week period, which has distorted the balance between the good and the bad ones. From the exam perspective, do remember that the number one antibiotic contributing to this manifestation is not to be answered as clindamycin. Yes, clindamycin is one of the important reasons, but not the number one. On a comparison basis, cephalosporins are to be given priority over clindamycin, and do remember the fact that they ask both things. One, they ask you the antibiotic responsible, and second, they ask you which antibiotic will be given to treat this condition. That again has a lot of controversies, so I'll try to resolve them when the time comes. But the basic message is, if a person has taken a course of antibiotics in previous 3 weeks, there's going to be distortion of balance and Clostridium difficile overgrowth will be seen. The antibiotics incriminated are mainly cephalosporin and clindamycin. Obviously, cephalosporins written first, so they are to be answered. And well, how's gonna be the patient presenting to you? He's gonna present to you with explosive watery diarrhea following this course of antibiotics. Most of the time, he can waste your subsequent precious seconds in the exam by writing non-specific complaints which are anyway associated with diarrhea. Like, he can talk about cramps, he can talk about this abdominal pain and the patient not eating well, and this has been continuing for fairly long. But the key or the main clinching point in the question would be that definitely that intake of antibiotic history will be given. Now, it's your responsibility to do a workup of this guy. Traditionally speaking, the first impression that I have seen a lot of doctors have is that we can straight away go for colonoscopy in these patients. But my point is that colonoscopy per se may not be available everywhere. And even if it is available, why would a patient say yes to an invasive investigation right away? So the first test that we can do for diagnosis of this condition is stool culture. But there are two limitations here. One, that you see the number one bacteria in the intestine is not E. coli. I hope you're clear about it. The most common bacteria in the GI tract is anaerobes. So you need to basically find Clostridium difficile among so many bacteria in the bubble is like looking for a needle in a haystack. So you need a very skilled microbiologist and at the same time a very dedicated microbiology lab which can pick up Clostridium difficile per se on a stool culture. So though it looks very good writing stool culture first, but at the same time the limitation is from the microbiology side. So to bypass this, what we did was we started doing a screening test for this condition, that is a stool ELISA. What are we gonna check for? We're gonna check for glutamate. Do remember the statement of mine, the sensitive test, that is the initial screening test or sensitive test, because screening test has to be sensitive. Remember, stool ELISA for glutamate dehydrogenase, which is produced by this bacteria, is the most sensitive test for this condition or is gonna be useful as a screening procedure. Now we need to obviously confirm the diagnosis. Lots of time in the exam they ask you investigational choice, so we are gonna go for PCR because PCR obviously the accuracy will be higher as compared to that for ELISA any day. So what are we going for? We are going for PCR for Clostridium difficile. You see, this is the nasty guy who's responsible for everything, and this bacteria would be having genes, and those genes are the ones which are going to be producing toxins. The toxins are two of them, that is toxin A and toxin B. So I would like to definitely identify that there is a bacteria which is having a gene that is producing these toxins, which can be identified by a PCR. Apart from this, we can also go for stool ELISA for these toxins also. Now, I want you to remember that there was a question in the exam where stool ELISA for toxin A, toxin B, as well as PCR for Clostridium difficile gene was given. If both of them are given, then the first answer that you need to give is what I've highlighted here already. Point number 3 is the best test for this condition. We can also go for colonoscopy. We can even go for histopathological evaluation. But then, as I said, invasive investigations are something that patients may not like. In these patients, when you scan with the help of a colonoscope, that is mainly in a research institution, or a person is having persistent disease not responding to the standard treatment, that is when you do a colonoscopy in this patient, you will be able to notice that in the colonic mucosa there would be multiple exudates in the initial part of the disease, which will be 2 to 5 millimeter in size, and then these exudates will begin to coalesce, that is, they unite with each other, and once these will coalesce together, that is when this appearance will come up, that is appearing like a pseudomembrane. I repeat the statement once again. Do not answer colonoscopy right away for diagnosis of this condition. But yes, if the condition is persistent, not responding to antibiotics, and has occurred maybe second, third time in a person after course of antibiotics, you have done a colonoscopy, either you will see these whitish exudates or they have united together to form a pseudomembrane. That's why the name is pseudomembranous colitis. In clinical practice, nobody will do a biopsy in this case. Well, if you look at this histopathological image, I am very sure you can pick up that this is bowel. Well, you can see all these glands. You can notice some goblet cells there. So I can say that because I'm seeing goblet cells, I'm seeing these glands. So this is definitely GI. And now you can see this like a mushroom cloud. See, this is an inflammatory exudate which is present here. This is like a mushrooming cloud that you can see here. So if they give you this image or this kind of image where you see over the bowel wall a mushroom cloud developing with distortion of the bowel architecture with lot of neutrophilic infiltration present, that would be a histopathological domain for PMC. But in practice, we do not go in for a histopathological sections. We usually avoid going in for colonoscopy in this person. The diagnosis is mainly based on non-invasive methods. I've just mentioned the findings of colonoscopy already to you in my previous slide. And I've also mentioned the histopathological findings, but I highlight once again, non-invasive investigations in GI are always to earn everywhere, whatever be the domain, but GI specifically. I mean, nobody would like a scope to go inside his body. He'll say, sir, can't you evaluate me without sending in a scope? So it is gonna be PCR for Clostridium difficile gene for toxin A, toxin B, that will seal the diagnosis. And now's the time for treatment of this chap. Here again, I would like to resolve this controversy by highlighting that if the MCQ says what is the best treatment for this condition, the answer is oral vancomycin. The problem is that in a country like India, oral vancomycin may not be available. Now, because oral vancomycin is not available, so lots of time in your OPDs, you would see your physicians writing oral metronidazole for these patients to restore the balance. Other antibiotics that can be used for treatment of this condition are fidaxomicin. Fourth one that can be used is teicoplanin. So these are other molecules which can be useful. And I'm not saying that teicoplanin efficacy is lesser as compared to vancomycin. It is just the fact that they have just written vancomycin oral first and then the subsequent molecule. So that is how we frame the answer to this question, that oral vancomycin is the best one. In some cases, there is also a tendency for patients to have recurrent pseudomembranous colitis, as I was saying. Now, this is a cause of concern, and here a very surprising thing is what we do, apart from the course of antibiotics, is that we will be going in for what I can see casually as fecal transplantation. Well, looks very shocking because we do a cornea transplantation, cardiac transplantation, lung transplantation. I'm telling you, fecal transplantation. You are taking feces of a normal person, putting it into a person who is having recurrent pseudomembranous colitis. You are giving this feces either via NG tube or maybe via the colonoscopic approach. But the point is that when you read about this extreme measures being taken because you want to establish the balance between the good and the bad ones, this is referred to as fecal microbiota transplantation. This, however, as an approach is useful for patients of recurrent pseudomembranous colitis. At this junction, because I had shown a colonoscopy image to you of those whitish exudates that were looking like a pseudomembrane, and in the exam, you will notice that very frequently they're giving colonoscopic images or they're giving upper GI endoscopic images. So one more miscellaneous fact I'll say before I move on to talking about ulcerative colitis. In this image, I have shown a upper GI endoscopy image, which is going to be showing a very peculiar concentric, you can see those concentric ring kind of an appearance inside the esophagus. The term that is used to describe this concentric ring appearance inside the esophagus is called as feline esophagus. Feline would mean a cat. Now, I have never seen a cat's esophagus. I mean, that is textbooks are saying. So we are assuming that a cat's esophagus would be, very irregular, very corrugated because they tend to eat almost everything we can't. This feline esophagus was an endoscopic image / a theory-based question. And the question said this is encountered in. What I found was a lot of websites, a lot of apps answering this, and even, on the Facebook, etc., various forums of various experts mentioning it as associated with gastroesophageal reflux disease. I want to quote Harrison in this case. If you go through the GI section in Harrison, it clearly mentions that feline esophagus is a feature of eosinophilic esophagitis. It is a different thing that eosinophilic esophagitis is AW, that means associated with gastroesophageal reflux disease. But the reason why I've highlighted this at this juncture is one, to highlight colonoscopic image of PMC you should be able to identify, and second, this irregular esophageal appearance with this corrugated ring appearance is what is called as feline esophagus. The primary answer is eosinophilic esophagitis. To confirm the diagnosis of eosinophilic esophagitis, obviously I need to do a biopsy, because I want to demonstrate the eosinophils. Next, what I'm saying is optional for you, that is written in the textbook, that if you are able to identify more than 15 eosinophils per high power field. You see, you have taken a biopsy in this particular chap who's having symptoms of persistent GERD or might be even having allergic conditions like asthma. So when we study GERD, we study about asthma, we study regarding allergic manifestations. That is when eosinophilic esophagitis also has to be kept in mind. And the image was mainly highlighted to explain to you regarding